Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, colleagues. With great pleasure, we will be having a spotlight tonight on the obesity and obstetric gynecological diseases, obesity, the relation between both and its impact. This lecture is endorsed by EMA Obstetric Gyne Society, and it's also in collaboration with Novo Nordisk. And I think there's a lag. Next slide, please. I would start by introducing myself. I'm an obstetric gynecologist specialized in aesthetic gynecology. I am also the vice president of the Obstetric Gyne Society under the Emirates Medical Association. I have worked for a couple of years within a women team to fight obesity, which was a bariatric team at Al Garhoud Hospital. I currently work in Al Garhoud Hospital and at Maison Laetitia, both in Dubai. I would like to introduce our two guests tonight. The faculty is Dr. Barbara Mcgowan, consultant endocrinologist at Guy's and St. Thomas Hospital at UK, and Dr. Saleema Wali, our colleague in Abu Dhabi Corniche Hospital, who is a chief consultant. Next slide, please. Our agenda for tonight is, as you see, detailed here. We are starting now and we will conclude, inshallah, before 10 p.m. There will be a series of discussions shedding the light on this important topic. Next slide, please. This webinar is submitted for CME CPD accreditation with Dubai Health Authority. And here I would like to start this evening. It's no surprise that obesity is a global pandemic. It is linked with multiple health complications, including heart disease, type 2 diabetes, and certain types of cancers. There are more than 650 million adults that live with obesity. 150 million of them are children and adolescents that live with obesity, and there are many countries that have put many initiatives to fight obesity, especially in children and adolescents, as it has an impact on the future of these individuals. 45% of people with obesity are not diagnosed. We only see that they are obese, and less than 20% of people with obesity are actually receiving evidence-based anti-obesity treatments.
Dr. Alia, apologies to interrupt. Would it be? Yes, thank you.
Yeah,
the slide shows.
I thought it. Okay.
No problem. Thank you.
According to the WHO Global Health Observatory in 2016, obesity is internationally prevalent, with more than 15% of those being women. The prevalence of obesity in the Gulf specifically, as we see in Saudi Arabia, more than 70% have a BMI higher than 25. Bahrain, more than 66% have a BMI of 25. Oman, 63. Qatar, 72. Kuwait, 73. And the most relevant here to the UAE, more than 68% of them have a BMI of higher than 25 or 30. Of course, obesity around the world has health effects affecting more than 195 countries over 25 years. And this study actually reflects the study that was done on them. And the GBD in 2015, Obesity Collaborators is our source for this. As you see here, of course, the red represents the female against male obesity. And we see that UAE ranks 9th. So it's amongst the top 10 countries that have been identified with obesity. So we're talking about a very relevant percentage here, which is 19% of the women we see actually suffer from obesity. In the United Arab Emirates in 2014, 31% of adults in the UAE had obesity, costing the society of 8.1 billion for treating the health consequences. So 3 in 10 adults had obesity, which is with 2.3 million, which is equivalent to 2.3 million. So that forecasts that by 2025, we will have 39% of the adults having obesity if action is not taken. And that was going to cost more than 3.1, which means it's going to have its impact on more than 3.1 million. So we're talking about more than 15,300 adults who die from overweight and obesity-related causes have been reported in 2015, which means 42 deaths daily. So in UAE, $3,540 was the average healthcare cost of obesity-related complications per person with obesity. And UAE has invested 154 million between 2014, intends to invest between 2014 to 2025 for treating obesity, could successfully reduce the adult prevalence of obesity by 1% by 2025. This was calculated by the World Obesity Federation. In 2017, anti-obesity medication represented only 0.74% of the total cost of treating consequences of obesity, although the country has put a lot of initiatives to fight against obesity, but the actual people with obesity are either not diagnosed or not treated. Of course, as you know, obesity is associated with multiple comorbidities. May they be metabolic in the form of asthma, fatty liver, gallstones, and we all know that females, obese females, are at a higher risk for cancer and infertility. They suffer from type 2 diabetes or pre-diabetes status, thrombosis, gout, cardiovascular diseases such as stroke, dyslipidemia, hypertension, coronary artery disease, coronary heart failure, and pulmonary embolism. And we know that almost in every house there is someone suffering from that. So add to that the family history. Obese females have sleep apnea, chronic back pain. So add that to all the other trauma that a female may go through throughout her life. They are at higher risk of having arthrosis, physical functioning, and urinary incontinence. And of course, there's a mental health impact of having depression, anxiety, and they become socially withdrawn. When looking into the gaps of obesity management, a study of 14,502 people with obesity, we found that 54% have actually discussed weight with their healthcare practitioners in the past 5 years. 36% were actually diagnosed with obesity, and only 21% had follow-up appointment call related to weight scheduled after their last visit. That is the end of my presentation. I would like to introduce Dr. Barbara Mcgowan. She's a consultant and honorary reader in diabetes and endocrinology at Guy's and St. Thomas Hospital. She was awarded a PhD from Imperial College in London 2007 for investigating the role of relaxin 3 on energy homeostasis and the hypothalamic pituitary axis, and the role of gut hormones and other neuropeptides and appetite control. She has a rich profile, but for the sake of time, we'll move on to the presentation of Dr. Barbara.
Thank you very much, Dr. Alia. I'm going to try and share my screen. There we go. Brilliant. Can you all see my screen?
Yes.
I'm assuming you can see my screen. Well, first of all, thank you very much for inviting me to speak to you about obesity and the consequences of women's health. This is a really important topic, and I think one that will become, I guess, even more important to discuss over the coming years, and perhaps something that has not really had the attention that it deserves. So I am an endocrinologist based at Guy's and St. Thomas's Hospital in London, where I lead the medical obesity service. And of course, I see a lot of women with all the complications of obesity. So hopefully I would like to share some of that experience with you today. And I'm going to first of all start off by describing obesity as a chronic disease, and then going through the impact of obesity on women's health, and then go on to sort of management and why weight loss is so important to improve many of the complications associated with women. So I'll start off by reminding everybody that, of course, obesity is recognized as a chronic disease by many important global bodies, including the FDA, World Obesity, several governments, and here in the UK by the Royal College of Physicians. So just to quote some of the quotes, so obesity is a chronic, relapsing, progressive disease process, and of course needs a chronic treatment. So this is reasonably well established, although there are some governments, and even here in the UK, for example, our own government still does not recognize it as a disease, which can be problematic, of course. And there's still quite a lot of stigma around obesity, as if obesity is somebody's fault, rather than actually, recognizing all the biological and genetic factors associated with obesity. So how do we define obesity? Well, sort of at a simple level, we, of course, at population level, we use BMI, and within those BMI ranges, where usually sort of 20 to 25 is sort of a normal weight, and 25 to 30 is overweight, and over 30, you're in the obesity category. There are some adjustments of ethnicity. So with the Asian Indians, sort of at 2.5 BMI is usually lower. Everything is shifted down by 2.5 BMIs. And of course, that works reasonably well at population level, but at individual level, really, it's perhaps doesn't work so well. And a lot of, the metabolic complications associated with obesity is really where the fat is. And that's why waist circumference can be sometimes more helpful. And here are some of the cutoffs that, points that we use sort of internationally for men and women. So 94 centimeters for men and 80 for women. But again, these are reduced for the Southeast Asian population to 75 and 72. And of course, then you can see, if you're over 102 for men and 88 for women, substantially increased waist circumference. And as I mentioned to you, it's not really just about total fat, but where the fat is. And so, we don't worry so much about subcutaneous fat as much as the visceral fat. And it's the visceral fat around organs such as the liver and the pancreas that causes metabolic issues. It causes insulin resistance. It causes, obviously, glycemic impairment and leads to type 2 diabetes. So that's the fat that we worry about. And that's why sometimes BMI is not such a good measure individually. This slide is really just to remind you that fat is a metabolically active organ. So it's just not just a lump of fat that sits there. And these are just some of the endocrine, autocrine, and paracrine hormones that it secretes. So you can see there are many of them. And of course, they all play quite a significant, important role in appetite controls, you know, some, as well as sort of getting involved in other systems such as renin-angiotensin systems, inflammation, interleukin-6, TNF-alpha, and so on and so forth. And of course, you know, adipose tissue also secretes leptin, which is a very important hormonal signal that tells the brain, you know, about our adipose stores. And the more adipose we have, the more leptin we make. That tells the brain actually to sort of reduce appetite, so to speak. And the other thing to understand is that excess abdominal fat is typically associated also with increases in the CRP, so inflammatory markers, increased free fatty acids, and also adiponectin. Okay, so how is appetite control? So, you know, at a very sort of simple levels, we do have this equation, which is the balance between energy intake and energy expenditure. But of course, there are many factors, many biological factors, you know, controlling that equation. And some of these are modifiable and some are not modifiable factors. So, for example, we can't do very much about our genetics, but of course, you know, genetics can account to up to sort of 70%, somewhere between 40 and 70% of our weight. So that is very important, but not much we can do about it. The amount of adipose tissue and the guts, you know, there are these, you know, gut hormones responses and adipose responses, as I mentioned, that, you know, all lead to appetite effect. So from a gut, we know, for example, that we have ghrelin, our hunger hormone, as well as a variety of satiety hormones, including GLP-1, you know, PYY, and others. And of course, some of these have now been harnessed into medication for the treatment of obesity. We also know that medication, of course, can cause, can lead to weight gain. So especially a lot of the antidepressant drugs can really be culprits in this respect. And then, of course, we have, you know, other things like the hedonic input, which is, you know, the experience or palatability, the pleasure of food, which will also play a part. The environment, you know, we live in an environment where there's more and more food available. And sometimes it's very difficult to make the right food choices because they're highly palatable, they're energy dense foods. And then, of course, we are all doing less physical activity, which, of course, hasn't been helped by COVID. And of course, all of these will be integrated at the level of the brain to affect energy intake and energy expenditure. So for our first interactive questions, you know, our first speaker mentioned that obesity is associated with lots of complications. Can I ask the audience to vote on whether you think that these are 0 to 50 or 50 to 100 or 100 to 200 or about 200? So I'm very keen to see the results of the poll. So I should be able to see the results coming up on my other screen, but if not, somebody might have to shout out the results. So please vote. Okay, so I think I'm seeing that the majority, okay. So we've got, I think, 67% saying that, or 75%, 50 to 100, ooh, okay, it's changing all the time. So anyway, about 20% of you saying 0 to 50, another 43 or so saying 50 to 100, and about a quarter of you saying plus over 200. And it's, of course, changing all the time. But I think the majority of you think it's less than 100 anyway. So I don't know whether we can share the results. Can we share the results on the screen? Or maybe you can all see them, but essentially the correct answer is actually over 200, and I'm going to share what the evidence is about what these complications are. So this is really the strength of evidence. So, and I know you can't read some of these complications, but this is the weak evidence about the association of obesity with these complications. This is the moderate, strong evidence, and you can see that there are more than 229 complications affecting every organ system and medical specialty. So I'm delighted to be talking about the gynecological side of things, but you can see that obesity really pretty much affects every organ, and the number of complications are enormous. And I'm going to talk through, like I said, the gynecological ones today. I also wanted to remind you that, of course, obesity increases the risk of mortality. And you can see here in this graph that as BMI increases, both for male and females, the risk of mortality increases. Of course, at very low BMIs, that risk goes back up, of course, because to some extent, adiposity is also protective. But you can see clearly that there is a risk as BMI increases. So what are some of the complications of obesity in women's health? So they're listed here in this diagram. So there are gynecological cancers, which I will talk to you about, pelvic organ prolapse, problems with urinary incontinence, infertility and sexual dysfunction, acne and hirsutism, polycystic ovarian syndrome, which of course we're going to talk about today. Then, of course, there's a huge area of pregnancy and fetal complications for mothers who are overweight. There's all the mental health side with depression and anxiety. And then, as you can see, another loads of other things, menstrual irregularities, risk of clots and postoperative complications, endometrial polyps and fibroids, cardiovascular complications, difficulty in getting pregnancy, and of course musculoskeletal pain. So you can see that we're really dealing with quite a vast number of issues. And as we start off, I just wanted you to concentrate on this clinical case and really just to picture this, because the problems with obesity can start from when we're very young. So here's a mum that comes to pharmacy with a daughter, Nadia, who's aged 12 years, and she's experiencing long and painful periods as well as mild acne. And Nadia's BMI is already 28, which is already considered to have obesity according to her age. And she's suffering from anxiety and mild depression and cannot focus on her school lessons. So I'm just going to leave you with that thought. And so if we really talk about polycystic ovarian syndrome as a starter, what we can see here is that as we increase the weight category, the weight class, the prevalence of PCOS increases. And in this particular picture, you can see both the diagnosed in the black and the but all PCOS in the gray for each weight category. And of course, what you can see here is that there's a lot of undiagnosed PCOS out there as well. And these are using NIH criteria, which I'm going to describe in a little while. So as the message here is lots of undiagnosed PCOS, and as obesity increases or BMI increases, there's more PCOS prevalence. Now, if we go to our next question then, how can you diagnose polycystic ovarian syndrome in adolescents? And there is a choice of 4, so good family history, exclusion of other causes of hyperandrogenism, complete hormonal and metabolic blood tests, or all of the above. And I would invite you to vote and see how you get on. Okay, brilliant. So I think everybody is okay, it's still trending a little while. It started off at 100% all of the above. Some of you are now saying exclusion of other causes of hyperandrogenism. So I think probably all of the above is the correct answer, because of course we still want to take a good family history, and absolutely we want to exclude other causes, cortisol excess, for example, or CAH, or other, obvious causes of hormonal causes or genetic causes sometimes of obesity. And then do a complete hormonal and metabolic blood workup to confirm the diagnosis. So let's talk about PCOS a little bit. Now, the pathophysiology is complex and actually remains largely unclear. But there are lots of contributing factors, which I've highlighted here, including a genetic predisposition, the fact that there is a hormonal imbalance with about increased androgens seen in 60 to 80%, as well as raised insulin levels, suggestive of insulin resistance in up to 80% of patients. What's also common is obesity in 60 to 80%, although of course we can also have lean PCOS. Our ladies usually experience ovarian dysfunction with oligoamenorrhea in 70 to 80%. And there's also some association with hypothalamic pituitary abnormalities. And you're all very familiar with the characteristics of PCOS. So ladies can present with hirsutism, and which can be really quite distressing at times. Often they have irregular periods, so they have that are either irregular or sometimes they stop menstruating altogether for periods up to a year sometimes. This, of course, leads to infertility. Some of the signs that they have, of course, are very indicative of insulin resistance, such as acanthosis nigricans with those dark patches, especially around the neck and the underarms. And then on ultrasound, polycystic ovarian morphology can be present in over 80%, but you don't necessarily have to have a polycystic ovarian morphology to make the diagnosis. And in terms of the diagnostic criteria, we have the NIH, the National Institute for Health criteria, the Rotterdam Criteria, and the Androgen Excess PCOS Society criteria. I tend to use the Rotterdam criteria, which is 2 out of 3. That's first, what we call irregular periods or oligo-ovulation and or anovulation, and clinical and or biochemical signs of hyperandrogenism. So they can other kind of clinical features or on blood tests, we see evidence of raised androgens. And then the third is polycystic ovaries on ultrasound. But as I mentioned, if you've got number 1 and 2, you don't necessarily need the appearances of polycystic ovaries. And of course, you need to have excluded other pathologies. And in terms of the actual sort of pathophysiology of it, where of course we know that obesity drives hyperinsulinemia, so we've got increase in levels of insulin resistance, and that can also lead to hyperandrogenism, ovarian dysfunction, menstrual disturbances. We also see lower level of SHBG, which also drives hyperandrogenism because there is less bound testosterone to SHBG, so more free androgens. And of course, on the other side, the insulin resistance also drives type 2 diabetes and increased cardiovascular risk. And what are the possible long-term risks of PCOS? Well, there are many, and they've been listed in this cartoon. And these include, of course, subinfertility, obstetric complications, also malignancies, which are associated with increased obesity, cardiovascular risk, and and also psychological complications. So let's look at these obstetrics and metabolic complications in a little bit more details. But what we know is that there is a significant increase in the risk of gestational diabetes, preeclampsia, and preterm birth in ladies with PCOS. There's also a threefold increased risk of impaired glucose tolerance, type 2 diabetes, and metabolic syndrome, whereas women without PCOS. And also, cardiac heart disease risk factors increase, such as increased, total cholesterol and LDL. So we need to be aware of this. How do we manage PCOS? Well, to some extent, we need to understand what the problem is. Some ladies present with weight as a problem. In fact, I would say the majority, weight is an issue. Then there's the problem of hyperandrogenism, and what do we do about the androgens? And then the third, I guess, is fertility. How do we regulate periods? How do we increase their fertility? So to some extent, we need to address the problems, and it might be that we need to do all three. So each patient will be different. But certainly what we do know in terms of weight loss, that 5 to 10% weight loss can really help with improving metabolic dysfunction and also increasing, improving periods. So that is something that we absolutely need to address. And with the hyperandrogenism, this is obviously beyond the scope of this lecture, but of course, we can use, the combined contraceptive pill, we can use anti-androgens, we can use laser treatment. And of course, for fertility indications, certainly we try to use metformin as probably first line to try and reduce insulin resistance. But then we have all these other interventions, ovulation induction agents, gonadotropin, laparoscopic ovarian surgery, and of course bariatric surgery and anti-obesity medications to really sort of tackle this problem.
Dr. Barbara, 1 minute.
Okay, so weight loss improves clinical features and long-term metabolic health. So I'm going to sort of hopefully describe that, you know, that weight loss is really helpful to improve some of these. So here's is clinical case 2, and this is a 32-year-old female, you know, presented with menstrual irregularities and subfertility. She's married for 8 years and had a history of 3 miscarriages. She's oligomeric for the last 8 years, and last menstrual period was 6 weeks ago. So she complained about excessive facial hair. She took ovulation induction drugs several times, but she failed to conceive. Her height was 155 centimeters, weight 79 kilograms, that should say, with a BMI of 32. And I guess the question for you is, what would be your first management recommendation? So would you arrange a biochemical workup to diagnose PCOS? Would you start metformin? Would you advise some weight loss through lifestyle intervention? Or would you advise weight loss through pharmacotherapy? Now, I know that we're running out of time, so but it would be good to see what the poll is suggesting, if you had time to suggest a question. So I think absolutely the first one, yes, arrange a biochemical workup for PCOS, because we do want to confirm the diagnosis, absolutely right. And some people are advising some weight loss through lifestyle, and the majority are actually advising weight loss through pharmacotherapy, which is very interesting. And you're absolutely right. So I think none of these are exclusive. I think, you know, I think all of them are very reasonable. So I think it very much depends on the patient. But I think absolutely right. Pharmacotherapy, in addition to lifestyle intervention, could really help us. Now, finishing off, and I don't want to forget about other problems with women's health, so urinary incontinence, cancer risk, and postmenopausal complications. Like I said, urinary incontinence is an issue, and I won't go into the details of this in the interest of time, but it does, again, increase with BMI, so we need to be aware of this. And again, weight loss recommendation for women is in the guidelines, including the American Urological Association, to help with urinary incontinence.
Dr. Barbara,
yes,
you can finish your slides
okay,
within 5 minutes, within an extra 5 minutes. Okay. This is
okay.
very valuable information. I think we all want to hear this.
Very valuable. Yeah, I don't want to rush. I'll go back. But so, okay, so urinary incontinence in women, like I said, and there are 2 types: stress incontinence and urge urinary incontinence, and mixed incontinence. But like I said, the prevalence increases with BMI. And there are guidelines to suggest that, you know, weight loss can really help with this, and we really need to think about this. So there are lifestyle interventions as first-line treatment, as well as, you know, other reducing fluids and caffeine and carbonated drinks, but reducing BMI to below 25 and pelvic floor muscle training can really help. Which is something we need to think about. Finally, I just wanted to highlight the increased risk of cancer with obesity. And as you can see here, there are at least 13 types of cancer which are increased with obesity. And especially to focus for our focus today is endometrial cancer. So women with obesity are 2 to 3 times more likely to get endometrial cancer. And for women who are, 23 kilograms overweight, they're 10 times more likely to get this. So any large weight loss will reduce cancer risk. Finally, in obesity in older age, again, older age and menopause are associated with an increase of fat mass and redistribution of fat to the abdominal area, again, increasing the consequences in such as type 2 diabetes and cardiovascular disease in the old age group. Also, obesity may exacerbate the decline in physical function related to age, leading to social isolation. The final point to make is that, and I'm going to actually skip to this slide. So benefits of 5 to 10% of weight loss have really been shown to reduce a number of risk factors, such as reduction in risk of type 2 diabetes, reduction in cardiovascular mortality, improving in lipids, in blood pressure, improving sleep apnea. But different amounts of weight will be needed to achieve improvement in certain complications. So you can see here that, for example, if we look at stress incontinence, we're looking at 5 to 10%. For PCOS, it can be anything between 5 to 15%. So it depends on the complication. We will require different weight loss, and sometimes we need more than what we can achieve just with lifestyle alone. So to conclude, I'd like to say that PCOS is the most common endocrine disorder in females with a high prevalence. There is no approved medication, and the pathophysiology is not clearly understood. The PCOS and obesity are linked, and obesity contributes and exacerbates complications of PCOS. I've mentioned that weight loss in women with obesity is the recommended first-line treatment for PCOS. Of course, anti-obesity treatments, including medications and bariatric surgery, should also be considered with women with obesity and PCOS. And you know, every case needs to be discussed individually. And finally, obesity is associated with urinary incontinence, increased cancer risk, and postmenopausal problems. So with that, I will stop sharing my slides and happy to take any questions in the Q&A. Thank you.
Thank you, Dr. Barbara. We will keep the questions to the Q&A session. I would like to introduce to you now Dr. Saleema Wali. Dr. Saleema Wali is a consultant obstetric gynecologist chairing the Academic Affairs Department.
Just a little bit of, as it has been alluded by two speakers before, how big is the problem of obesity all over the world. About 650 million adults being obese, which is about 12% of the population.
You can continue now, please.
About almost it's equal between the men and women, but if you take women as the reproductive age, they are more obese than the men. The prevalence of obesity has tripled from 1975 to 2016, which is the last data on it. So what's infertility by definition? It means failure to conceive after 12 months of regular, unprotected sexual intercourse. How many couples globally are infertile? Are 50 million couples, which is a huge, huge number. That means instance about 10 to 17%. It's not only to have the babies, but it has have a lot of negative impact on psyche as well as on the quality of life. It does have adverse effects on the menstrual and ovulation. It does give rise to subfecundity and infertility. It increases the risk of having sexual dysfunction. And not only so, even though they go for treatment of the fertility treatment, the success rates and even the safety is a concern, and they have the poorer obstetric outcomes in comparison to the normal BMI women. This is a study which has been published from Netherlands, and it's very valid point that obesity and fertility, there's a big association. About 78% of the women with fertility issues have an obesity, and about 27% with overweight. So what was the most important point was, if there is increase in BMI only by 1 point, it reduces the spontaneous pregnancy rate by about 10%, which is huge. If somebody increases the BMI by 2 points, that means the odds of having spontaneous pregnancy is reduced by about 20%. Then what is the reason for this? The pathophysiology of this is quite complex. But if I take the main important points, that's there is disturbance in the hypothalamic pituitary gonadotrophin axis, and I think that was previously alluded that it leads to hyperandrogenism, and that leads to ovulatory dysfunction. This is because of the effect increasing the luteinizing hormone, reducing the sex hormone binding globulin, and increasing androgens and decreasing estrogens. So again, the quality of the oocytes is affected as well as the number, and this is leading to the reduced ovarian reserve because of the insulin resistance as well. And there are lots of indirect effects of this on the fertility. And one of the main things is because of the increased triglycerides and fatty acids, they increase the insulin resistance. In addition, there's a very high levels of adipokines, which decrease the responsiveness to the gonadotrophins, steroidogenesis, and again, if there's a developing embryo, it causes the damage to it. There's also even in the effect on the meiotic divisions and mitochondrial dynamics of oocytes and pre-implantation embryos. There are a lot of negative impact even after fertilization. Again, as we heard before, it does cause inflammation, coagulation, and fibrinolysis effects. They all are going to cause indirect effect on the fertility. This is one of the early, if you remember, the oldest studies are by Sten Leventhal. When he looked into amenorrheic women, what did he find? That about 48% of these amenorrheic women were having obesity in comparison to the 13% in the women who have normal menstrual cycles. And this is the latest studies which have been published. And this is as the BMI increases, the cycle length increases, and the same applies as the BMI increases, there is increase in the irregularity of the cycles. So if we take overall, about 1 in 3 women who are obese can have menstrual cycle irregularities, and with each increase in the degree of weight, there is increased association of having either irregular cycles or long cycles. So it does have a significant effect on the ovulation as well as the menstrual cycles. What about the abnormal uterine bleeding? It does have an effect, especially it can cause obesity, can lead to early onset menarche, but which leads to early ovarian failure, or it may lead to the early menopause and longer and more irregular menstrual cycles in their lifetime. What is the mechanism for having this abnormal uterine bleeding? This is very complex and not known, again thought to be related to the estrogen because of the peripheral conversion of the androgens to the estrogen, and as well adipokines are labeled because of its effect on the hypothalamic pituitary gonadotrophin axis can lead to irregular cycles. And in addition, the third important point is about hyperinsulinemia and the insulin resistance, which intensifies the activity of the luteinizing hormone in granulosa cells, leading to the premature luteinization. So lots of effects, quite complex, not precisely known, but still some idea what leads to what. Now, if these women are given fertility treatments, whether it's oral or injectable, the response to the ovarian stimulation is decreased. But what has been found that even if we are giving oral clomiphene, the birth rates are not as good as have been seen with letrozole. In addition, if you are going to give them gonadotrophins for fertility treatment for ovulation, the response is lower. Not only that, they require the gonadotrophins for a longer duration, and the amount required for ovulation induction is much, much higher. And there is higher rate of having cycle cancellation, and what is retrieved after ovulation induction is very few oocytes with a poor quality. Again, the quality of the embryos in obesity, as you see, the body mass, as the body mass index increases, the size of the oocytes decreases progressively. And same applies even though they get fertilized. As per the BMI, they don't reach to the Hatch-Blastocyst, gets lower as the BMI, if you compare the BMI less than 25 and more than 25. So what it means that there is something in the follicular environment which is possibly again related to the same, that's higher insulin, markers of inflammation, and higher free fatty acids. And in addition, there is something to do with the cumulus around the oocyte, which is abnormal. And as I showed before, the oocytes are quite smaller and the BMI in the high obesity. And this will lead to lower implantation rates, lower clinical pregnancy rates, not only so, even lower birth rate if they get pregnant as well. What are the effects on the embryos if they get fertilized? They are of poor quality embryos. They are less likely to develop to full fertilization after fertilization, and they reach faster to the Morola stage. But what happens, the trophoectoderm, which is the future fetus, it has fewer cells, and there is a poor glucose and increased levels of triglycerides, which means that these quality of the embryos are quite poor to help in the fertilization and to reach into the stage of live birth. So what in conclusion it is that IVF success rates are highest in those who are low and normal BMIs in comparison to the high BMIs or obesity or morbidly obese. And this has a progressively and statistically significant worsening of the outcomes as the BMIs go higher. And quite a lot of studies and quite a number of patients have been analyzed, and that's more than 240,000 fresh autologous IVF cycles were analyzed and to see what the effects and outcomes are. What about if they get fertilized? What about the impact on the endometrium and the implantation? There is something altered endometrial genetic profile of the endometrium, and this is again related to that insulin growth factor binding protein 1, which is very important for helping in the adhesion during implantation and leading, which is also related to the leading to suboptimal desidualization and decreased uterine receptivity. And because it may be also related to because it's pro-inflammatory markers, they do have a negative impact on implantation rates in patients who undergo assisted reproductive techniques. What about if now even some of the studies were conducted by doing the ovum donations with the normal weight from the normal weight women and implanting these over in the obese women. The female obesity impairs the reproductive outcome of the ovum donations, probably as well because of the reduced uterine receptivity. Even though the embryo qualities, even though everything is normal, but there is a problem in the receptivity of the uterus. What does IVF experts find the difficulties? Because the difficulties are imaging is again very difficult in obese women, so they may not be able to visualize the ovaries very well under ultrasound for the follicular growth. There may be also, if they are going for oocyte collection, there may be difficulty in maintaining the airway during the oocyte collection because some of them may have its obesity, and as we heard before about sleep apneas, that can lead to the problems. What about the effect overall if they get pregnant? What about what happens to them? It has been found that women who are obese, they have higher miscarriage rates. And these miscarriage rates have been studied. In one of the studies, it was a meta-analysis on 47,000 women. And what was it? Normally, there is a pregnancy loss in normal women, but they are most of the times aneuploidies. But these patients who are obese, these women who are obese, they lose the pregnancies, which are even normal. Euploid pregnancy losses are even higher. And if they are conceiving with ART also, which is the assisted reproductive techniques, they have higher pregnancy loss of about odds ratio of 1.4. And even the recurrent pregnancy loss is quite higher in women who are obese. And now let me go a little bit about the obesity and about the male obesity. Does it have any effect? I just will again like you to vote on it. Is it a contributory cause of infertility? Up to 10% of couples experience difficulty in conceiving, or obese men have worse semen analysis parameters than men with normal weight. If we have the voting on this question as well. So let me move on with the male obesity and reproduction. The male factors contribute up to 50% of subfertility, and which is usually most of the times ignored. And if you see, they contribute 50%, but solely a male factor is responsible in 1 in 3 couples. And this is because obesity declines the semen quality, there are endocrine alterations, there is sexual dysfunctions, there are associated medical comorbidities, diabetes, and other sleep apneas, and even the rise in the temperature in the scrotal area, which can lead to the hyperthermia and again destroy the quality of the sperms. And again, pathophysiology for this is again disturbance in the hypothalamic pituitary testicular axis, and again having hormonal effects, effect on the quality of sperms, including the damage on the DNA, increased impairment of physical and molecular structure of sperms, and reduced sperm concentration, the motility, and even the ectosome reactions. And the indirect effects, again, are because of chronic inflammation in reproductive tract, increasing the temperatures, again, abnormal levels of the adipokines, oxidative stress, and as well having the erectile dysfunction due to peripheral vascular diseases. What is the relationship between BMI and waist circumference on semen quality? Again, it's from the life study. The male infertility is increased, and again, it is again related to the subcutaneous as well as the visceral fat. It's multifactorial, increased chances of abnormal semen and parameters leading to subfertility. And as well, there is a linear decline in the ejaculate volume as the BMI increases, as well as the abnormal sperms morphology, as well as the count. These are meta-analysis on BMI and sperm parameters have shown the sperm count can go down by about 2.4% and concentration by about 1.3% and the volume by about 2%, which is a significant reduction in the quality of the semen. And what should be the treatment? Ideally, the treatment of obesity, as has been already covered in polycystic ovary syndrome, this is from the Androgen Society, that's lifestyle modification. So we have to focus on the lifestyle modifications and weight loss, as we know that it will improve the outcome in women with fertility or infertility. So if I have to say anything in the first point is lifestyle modifications should be used as the primary therapy in overweight and obese women. And this may improve the ovulatory function as well as the pregnancy rates. But how easy it is to do the lifestyle modifications and to get the weight reduction is not that easy, because it's very difficult for most of the people to sustain that weight loss. And what is the conclusion of these lifestyle intervention? Another meta-analysis and systematic review. Again, the conclusion was that lifestyle interventions in obese infertile women based on dietary restrictions and physical activity will lead to slightly increase in the pregnancy rate as compared with the usual care, but makes no difference, very little difference as far as the live birth rates are concerned. So the first important point is, yes, again, the stress on the weight loss, and that will improve the reproductive outcomes because of regularizing the menstrual cycles, increasing the chances of spontaneous ovulation and conception in an ovulatory overweight and obese women. How much is the weight loss required? It was previously shown that, yes, it depends on whatever is the underlying cause and what's needed to improve on. But for fertility point of view, even the 5 to 10% weight loss does improve the fertility rates. And this is weight decrease improves the live birth rates. Now it depends what type of interventions you are going to do. These are some of the randomized studies in which they use diet and exercise control. They use diet alone versus controls, and randomized studies using different weight loss medications versus controls. And what at the end of the day, their pregnancy rates per cycle attempt was improved. Pregnancy rate per embryo transfer was improved, live birth rate per initial cycle was improved, and live birth rate per embryo transfer was increased, and cumulative live birth rate per initial cycle was improved. So important that weight loss resulted in increased cumulative birth rates. So medical management, if it doesn't, usually is not that easy to manage, the medical management is other option, which is the weight loss medications with lifestyle interventions are better. And it can be that you target on the appetite or block the absorption of the fat and reabsorption of the glucose. But again, it is used as an anti-obesity medications during pregnancy or in PCOS are not recommended. But if you have to use it, you have to make sure about when to start. There are some of the studies where they have reported the cases of pregnancies after medications, but again, these are only registries, and there has been increased risk of having even the congenital abnormalities, even stillbirths. But again, it's very difficult. You need very large numbers to show that effect. What about the surgical interventions? I think it has become very common intervention in this part of the world, and we know that it's very effective intervention. It does lead to long-term weight loss. The weight loss can be as a mean of 30% within 12 months. It improves the endocrine and metabolic profiles, reduces the menstrual irregularities, ovulation, improves ovulation, hyperandrogenism, and hyperinsulinemia, and improves sexual function and pregnancy rates. But it is associated with certain problems during pregnancy, especially small for gestational age fetuses are increased in patients who have undergone bariatric surgeries. So weight reduction intervention for obese infertile women prior to IVF, this is one of the best is in randomized controlled trials. What they have shown the same as the outcomes change as the BMIs are increased. So if you have to improve, it depends upon underlying comorbidities, underlying BMI, where it may be important to go for the bariatric surgeries to improve the outcomes. What's a pre-fertility treatment advice you would advise to the women who are obese? Because obese women as well are associated with vitamin D deficiency. So one of the factors which has been found to be influencing female reproductive ability in our IVF outcomes has been prescribed for them vitamin D and adverse metabolic complications, and one needs to screen those comorbidities and before undergoing any assisted reproductive technology to reduce the risk of adverse pregnancy outcomes. I mainly mean like if they are diabetes, if they have other comorbidities, hyperlipidemia, or other hypertension or anything, we need to make sure that they are controlled before they embark on the pregnancy. So the approach in these mothers need to be multidisciplinary, and weight loss of 5 to 10% coupled with lifestyle changes improves the pregnancy outcomes. So the weight loss recommendations by behavioral modifications, even by pharmacological agents or bariatric surgery is recommended in morbidly obese women. My take-home messages are that the risk of anovulatory infertility is twice that of a non-obese woman. It does impair both natural and assisted conception results. It affects oocytes, sperms, embryo quality, endometrial receptivity, and implantation rates. The clinical pregnancy rates, pregnancy loss rates, live birth rates decline as the BMI increases. Obesity can compromise as well, can be compromised because it's very difficult to do any ultrasound imaging on these, and even the safety of oocyte retrieval at times can be difficult. There is an increased risk of having erectile dysfunction in the men, and that may be improved again with the weight loss. So I want to stop here and say thank you very much.
Thank you, Dr. Saleema, for this interesting presentation and for sharing your experience with these cases. We will move on to our next session, which with Dr. Barbara on medical management of obesity. Dr. Barbara, the
Thank you
floor
very
is
much.
yours.
Hi, yes. Would you mind, Dr. Wali, stop sharing the screens? Brilliant. Thank you very much. And I will. Great. Thank you. I shall. Hopefully, 2 seconds. Perfect. So thank you very much. And that was a wonderful talk. So reviewing all the evidence really with regards with weight loss and fertility. So I really enjoyed that. So thank you very much. And I think what I'm going to do now is talk a little bit more about the medical management of obesity and how we can lose weight with pharmacotherapy. So I'm just going to touch upon a couple of things. First of all, the importance of chronic management of obesity, what the international guidelines are, the role for medical therapy, and then talk to you about the liraglutide 3 milligram data and clinical trials. So I think, obesity is a chronic disease, and I think we need to treat it as a chronic disease. It's a little bit like treating blood pressure. If I give you a tablet and your blood pressure goes down, if I stop that tablet, the blood pressure goes back up, and obesity behaves very much the same. Now, it's also important to understand that I think we do have sort of limited options in terms of pharmacotherapy, but nevertheless, the need to treat is very huge, and we need to, of course, deal with the biology of obesity. So let's see where we are. So let's move on to guidelines. So most of the guidelines are, I guess, similar to some extent, they're based on BMI, and some guidelines are more based on the sort of complications of obesity. But on the whole, as you can see here, these are the different guidelines. It's a three-tier treatment pathway, which always starts with diet and exercise, which should always be the first intervention. Whether you're thinking about pharmacotherapy or surgery, diet and exercise should always be first. And then, as the BMI increases, as there are more complications of obesity, then, we're looking to add pharmacotherapy and then eventually to look at surgery. Now, the other intervention that we do in terms of when we assess patients is really to stage them, a little bit like cancer. And these are the Canadian Edmonton obesity staging criteria. And without going into too much detail, they're staged from 0 to 4, and they're divided broadly into 3 categories: medical, psychological, and functional. And so patients are assessed, and let's say we look at the medical risk factors. If there are no medical risk factors, the staging is 0, and then subclinical 1, all the way up to very severe disease, which is a 4. So here it is in a slightly more simpler forms, where the medical, psychological, and functional limitations are staged. And whatever the intervention, so for example, fertility that's what we're trying to destage. We want to render females from infertile to more fertile sort of stage, and destage them from, say, stage 2 to stage 1 or 0. And like I said, there's a stepped approach. So we always start at the bottom here with changing diet and increasing exercise, and then adding behavioral modification to those interventions. And then as the BMI increases, as you can see here, and as we're dealing with more complications, then we're looking to use pharmacotherapy, usually with a BMI above 30. Although if you've got obesity complications, you can start using medication at a BMI above 27. And then bariatric surgery, usually a BMI over 40, but usually 35 and above with complications. Now, there are different phases of obesity treatment. So the first phase is the weight loss treatment, which is actually the relatively easiest bit of obesity management. And then the more difficult phase, which is the weight loss maintenance, which is more tricky, of course. And if you have a treatment and you stop it, as I mentioned, the blood pressure example, the disease comes back, and that's the weight that comes back with all the complications. Now, I was going to ask the audience, and I think some of you have already answered, how much weight loss can be achieved with diet and exercise alone. I think the majority of you, answered 1 to 5%. Rather than 5 to 15%. And that's exactly correct. I mean, lifestyle intervention is somewhere really between 3 and 8%, depending on the intervention. And we need to look at sort of pharmacotherapy and or bariatric surgery if we want to look at sort of more significant weight loss. So here we are. So with lifestyle 1 to 5%, then with pharmacotherapy and lifestyle 5 to 15%. Although really the pipeline of pharmacotherapy is looking really good, and we may actually be able to go beyond that. But for now, that's what we have, and surgery sort of somewhere between 20 to 40% long term. Now, these are lots of different studies, lifestyle intervention studies, which have shown, as you can see, quite good weight losses, actually some really quite significant weight losses. But what studies have shown, all these lifestyle intervention, is that we follow up patients for 4 to 7 years, they've all regained that weight. Okay, so that's unfortunately, the reality of life. And why is that? I wanted just to explain what happens after weight loss. So if we have a diet, we go on a diet, we have significant changes in our hormones. So our leptin hormone will decrease because we've got less adipose tissue. Our ghrelin hormone, our hunger hormone, increases. Our satiety hormones decrease, so we feel less full. And not only that, our energy expenditure decreases by 15 calories for every kilogram of weight that we lose, which means that if we lose 10 kilos, for example, we need 150 calories less just to stand still, because our resting energy expenditure requirements are lower. So all of these changes basically means that we are destined to regain weight. We are fighting because we've got these inbuilt mechanisms that try really hard to preserve weight. And this is just to prove the point. I don't know how many of you watched this in 2014, The Biggest Loser finale. So these are all these patients living with obesity who entered this race, so who could lose the biggest amount of weight. And you can see Craig here going from 183 kilos to 103 kilos, losing nearly 80 kilos, 43% of his weight. But inevitably, if you follow all of the participants over time, they all regained a lot of that weight. So the competitors lost about 58 kilos at 30 weeks, but at 6 years, a lot of this weight, 2/3 of this weight was regained, 41 kilos, and the rest in metabolic energy decreased by 600 kilocalories per day. And then at 6 years, 500 kilocalories or so. And these are just the individuals, but just to prove the point that pretty much, as you can see, from 30 weeks to 6 years, most of them regained that weight. Fat-free mass stayed much the same, but fat mass increased significantly. We've talked about the fact that, diet and exercise should always be the first line treatment, but the success rate is relatively low over long term, with 2/3 of dieters regaining more weight than they lost on their diet. And that's when really pharmacological intervention is ultimately required to help with really maintaining that weight loss, or achieving more weight loss, but also maintaining the weight loss. So why do people living with obesity need pharmacotherapy? Like I said, I think first of all to try and really to interfere with sort of the signals, the brain's, those gut hormone signals which tell the brain that we are hungry. Because, of course, obesity is a global pandemic associated with decreasing life expectancy and severe complications. We want to treat those complications. We know that complications arising from obesity can be improved by weight loss, and we've talked about fertility and how it improves with weight loss. And like I said, it's so difficult sometimes to maintain that weight, and that's why pharmacotherapy can really help here. So what have we got in terms of medications at hand? Well, I just wanted to show you the medications which are approved in Europe and the ones approved in the States. I think the ones approved in Europe probably mirror more closely what you have available. So I think liraglutide 3 mg, which I will talk to you about today, is of course available. We also have orlistat. And the other medication that's approved both here in the States is a combination of naltrexone and bupropion. So naltrexone is used, is a medication that is used for opiate addiction and alcohol addiction, whereas bupropion is an antidepressant drug. And the two drugs at lower doses have been put together, and clinical trials have shown to be effective at weight loss. But so that's what we have, although we don't actually use this very much here in the UK because it's not NICE approved. We don't have phentermine and topiramate, phentermine or sibutramine, which of course was removed because of increased cardiovascular risk. But the States, they do also have these medications available. So let's talk about GLP-1 agonist, so liraglutide. So just to remind you about that GLP-1 is a satiety hormone, and it's normally secreted by the L cells of the gut, but it's also produced in the neurons in the hindbrain. And the expression of receptors is quite significant. You can see that lots of different organs that express the receptor. And of course, in the brain, it acts by reducing appetite and satiety, and hence body weight. And of course, it is also an incretin in the pancreas and increases insulin secretion there. So this is how, like I said, liraglutide 3 mg, which is an analog, a long-acting, well, it's got a half-life of about 13 hours. It decreases, so it acts by decreasing hunger and prospective food consumption and increasing fullness and satiety. Studies have also shown that it actually decreases visceral fat more so than subcutaneous fat in terms of relatively change. The findings, studies have also shown that if you give patients sort of chocolate drinks to look at and then to drink, and you look at the sort of areas of the brain which light up with functional MRI, GLP-1 receptor activation has shown that essentially GLP-1 decrease the anticipation of that food reward, which may reduce cravings. And not only that, it also increases the consummatory food reward, which may prevent overeating. So it's also acting on those sort of hedonic areas of the brain. So this is just to show you I guess, a summary of what the SCALE phase 3A clinical trial program, which essentially was a program taking liraglutide 3 milligrams, or Saxenda as we know it today. And so this is a phase 3 program. So the SCALE obesity and pre-diabetes was the largest program, and I'm going to show you some results. These are patients without diabetes, but some of them had pre-diabetes. Then the SCALE diabetes study, where patients with diabetes were randomized to liraglutide or placebo. And we had the SCALE maintenance study, where everybody had to undergo a lifestyle intervention first, and then randomized to either liraglutide or placebo. And then a much smaller study, which was a SCALE sleep apnea study, looking at the effects of liraglutide on patients with obstructive sleep apnea. So just to summarize roughly the results of the studies and the key outcomes. So roughly with the SCALE obesity and pre-diabetes, the mean weight loss with semaglutide at 1 year, with liraglutide was 8%. And not only that, there was an 80% reduction in the risk of developing type 2 diabetes. So, if you had pre-diabetes and by losing that weight, you reduce the chances of developing type 2, which of course is important. Patients with diabetes lost a little bit less weight, so about 6%. And we know that if you have diabetes, you're likely to lose less weight compared to patients without diabetes. And there was an improvement in HbA1c by 1.3%. SCALE maintenance, again, very good in terms of 81% maintaining at least 5% of weight loss after 1 year. And the group with liraglutide achieved an additional 6% on top of the original 6% achieved by everybody with lifestyle interventions. So it was very good. And again, with the sleep apnea study, there was some improvement in the apnea hypopnea score, which they used for sleep apnea, and about 5.7% change in body weight. So just looking at the SCALE obesity and pre-diabetes study, like I said, 8% body weight. You can see that versus 2.6 with placebo, and about 2/3 of patients achieving at least a 5% weight loss versus 27 in the placebo group. This is just showing the results for patients with normoglycemia and with pre-diabetes, and you can see the results at 1 year there. So that you can see that obviously with the Saxenda, that's the bottom, the line in the blue. Now, what's really important when we treat patients is to ensure that if they don't achieve at least 5% of weight loss at 60 weeks, when we've titrated the dose up to 3 milligrams, that we stop the treatment. And we call patients that respond, i.e. achieve at least 5% weight loss, as early responders versus non-responders. And what we can see here in this graph is that if you do respond, if you're an early responder, then you're going to achieve 11.5% weight loss at 1 year, so much better than the average of 8%. But if you do not respond, your average weight loss is only going to be about 3.8%. So it's very important to use the stopping rule and to stop. And we can tell patients that if you're one of these responders, your weight loss at 1 year is likely to be over 10%. Now, it's not just the weight that improves, but also lipid parameters. And you can see here that, HDL goes the right way. It increases. HDL is the good cholesterol. And then LDL, VLDL, triglycerides, everything sort of improves in terms of, liraglutide treatment. So it's all going in the right direction. And then if we actually look at sort of quality of life or health-related quality of life, so physical function, self-esteem, sexual life, public distress, and work, you can see that everything was significant in favor of 3 milligrams of liraglutide. Now, is it safe to use? Well, we are, I think, for those of you who practice diabetes and use GLP-1 agonists, we're all very familiar with the nausea and also vomiting, diarrhea, and constipation. But the nausea does improve over 2 to 3 months. There are other side effects, but most patients usually cope with it reasonably well, I have to say, and no really serious side effects. So again, this is just to show with the nausea. So we tell patients you are likely to experience nausea. You can see this is quite high in terms of percentages. They need 25% in week 4, but it comes down quite quickly. And by week 56, only about 5% are experiencing this. So if we let patients know, most of them will tolerate. So what about a treatment algorithm? Which sort of pharmacotherapy should we choose if we do have a choice at hand? Well, this is taken from the Canadian Clinical Practice Guidelines from 2020. And essentially the guidelines are saying that we should use pharmacotherapy for a BMI over 30 or a BMI of 27 plus complications of obesity. Of course, we should consider stopping or changing medications associated with weight gain if possible. And we also need to consider what complications of obesity patients have. But essentially, for those who have craving, depression, or are smokers, Naltrexone and Bupropion is a good choice because, as I mentioned to you, the combination, these drugs are used for depression and addictions. But otherwise, for those with diabetes, pre-diabetes, hypertension, OSA, polycystic ovarian syndrome, liraglutide should really be the first choice, with other drugs, naltrexone as second and orlistat as third choice. And then, of course, it's important to assess patients after 3 months. And like I said, to stop if they've not achieved adequate weight loss and or to think about trying a second line medication or to add on to the, to what they're on, depending on what sort of targets we're trying to achieve. In terms of, the effects on complications, so effects on NASH, PCOS, osteoarthritis, OSA, it's got to be said that many of these drugs, orlistat, liraglutide, or the combination of naltrexone and bupropion have really not been studied very much. Now, some, like orlistat, in terms of NASH, has not really shown any improvement on NASH. But on PCOS, for example, liraglutide has shown a 5.2 kilo placebo-subtracted weight loss at 6 months, but no data yet on menstrual cycles as such. So I think we need obviously more data specifically looking at complications. So like I said, liraglutide is indicated in addition to lifestyle intervention at a BMI of 30 or 27 plus at least one weight-related comorbidity, for example, PCOS. Like as mentioned, it should be discontinued after 12 weeks on the 3 milligram day dose, which normally means about 16 weeks because it takes about a month to get up to the 3 milligram dose. And so you should stop if you've not lost 5% of your body weight. Just to remember that actually in Europe, it's also licensed in adolescents with obesity from the age of 12 years. And these are patients with a BMI over 30 or a body weight, and the body weight above 60 kilograms. So we can use them in adolescents as well. How do we use it? So we start at 0.6 milligrams the first week and then titrate up to 1.2 after 1 week, then 1.8, 2.4. So every week and going up to 3 milligrams, hoping that they tolerate, sometimes if they get some nausea, I'll leave them on the maximum tolerated dose. But the idea is to try and get to 3 milligrams as quickly as possible. Of course, I should make the point that it should not be used during pregnancy or breastfeeding. So it's not licensed for pregnancy. So in summary, I think hopefully I've reminded you that obesity is a chronic disease with complications that require early intervention. And lifestyle changes, of course, is the cornerstone in obesity management, but they are less effective and they are challenging in maintaining weight loss for long periods. I've discussed the fact that pharmacotherapy is indicated when patients have a BMI more than 27 plus complications or BMI more than 30. I've shown you some of the results with the liraglutide 3 milligram, which is an effective treatment for obesity with an average weight loss of 8%, but more so, of course, up to about 11% if you're an early responder. And liraglutide has benefits beyond weight loss. And I've shown you some of the lipid and other cardiovascular markers. And with that, again, I'd like to thank you and happy to take questions in the Q&A. Thank you very much.
Thank you, Dr. Barbara, for this presentation. We will move on to our last session here. There will be a debate. Can gynecologists play a role in managing obesity? So I'd like to start with you, Dr. Saleema.
I just will share a couple of slides to show the role of them, if possible. Just 1 minute. Okay, I'm just going to start with the same point that obesity is highly linked with the women's health. And I think that's a very important. And first of all, we would like the vote again to see how much do you agree with this statement that obesity is highly linked to women's health? Strongly agree? Agree with somehow? I don't agree. Let's have a vote on it. I don't think anybody is voting on it. Of course, yes, 100%. Let me start the next now slide. The second statement is, do you see the gynecologist can play a role in fighting this disease? Yes, of course. And I agree, but I don't have time. And that's the most important. I agree, but I need to have more tools and knowledge. And I don't agree. And I think majority have answered the first question. They strongly agree with the second. I don't have it yet. I think it takes time to get that voting done.
Few seconds, Dr. Saleema.
I'm giving.
Dr. Saleema, the results are already published.
Yes, okay, I got it now.
It's
Well,
94%.
yes, I think most of them do agree with everything. And again, with the second statement, they think that it is linked, and they do start weight conversation, but I don't have a big number on it as well to say how much.
I think it's about 80% actually.
Good.
For number one.
Yes. They do see, but they usually start weight loss conversation, which is sometimes very difficult, I find, in practice to see. It's not that easy to start a weight loss conversation so easily. So I'm going to take why OBGYN need to know about obesity management. I think this is a very good, this is a very good to say about obstetricians and gynecologists strategy for patient initiation and maintenance of anti-obesity treatment with glucagon-like peptide-1 receptor agonist. And what it was that 37% of we have more opportunity as obstetricians and gynecologists to see the women during their reproductive age group especially. And they do come, majority of them, to us to find even the primary care treatments, which is about 37% as per the study. And we see we have more opportunities to meet them, whether they come for contraception advice, they come for a pap smear advice, or they come for during pregnancy, or they come after delivery to us. We do have opportunities to see them and to talk to them about it. We know that it is, even talking to them about obesity and its complications like infertility, high-risk pregnancies, or even cancers, as we heard a lot. There is a lot of opportunities for all of us to meet them and to talk about the obesity with these mothers. The guidance is, we need to first of all make sure that we recognize overweight and obesity women before pregnancy to allow the time for them counseling about the body weight, and which is majority of the times missed. And that's where we need the primary healthcare providers or the first level providers to help us in managing them before they come to us for any issues. And like in this part, it's very easy because they come to us mostly, whereas in many parts of the world, they will go to the primary care health providers. And to discuss routinely about the body weight with the patients, it's very important as a gynecologist and obstetrician to play an active role, to identify those who have high BMIs and to advise them about the weight management solution. we know that there's a lot of stigma attached to the obesity, but we need to be mindful to talk to them and be respectful and start a compassionate way to open the discussion, because you cannot say them about you're overweight or you're obese. It's how to, do you like to discuss about your problem of weight, or do you want to know anything what's available for the management? That's just to ask their permission before we start discussing anything regarding that weight, so that they are on board with us. We know there is anti-obesity medications in overweight and obesity, because we don't see the children, but more than 18 years of age, yes, these are recommended to prevent the development of obesity-related complications. And we want to increase their chance of getting pregnant, as we know that they are not they cannot be used during pregnancy, they cannot be used during lactation, and they cannot be used if anybody is planning to get pregnant. So we need to have, so yes, it can be used to the mothers who have delivered and no longer nursing now, or women who have not had children. There is an opportunity to improve and give them the advice on the anti-obesity medications. So yes, we heard a lot. Thank you, Dr. Barbara, to introduce audiences about liraglutide. But again, the problem is it's not approved for treatment of PCOS or in infertility, and it's not approved. 3 milligrams is approved for weight management, but these are patients, these are women who are not pregnant and who are not planning to get pregnant, both ways. So you can't advise much on this. So we have to, that means we have to provide them contraception at the same time so that they don't get pregnant at the same time. So again, helping patients with long-term treatment adherence is again an issue. So we need to persist in the anti-obesity medications. It's very important to achieve first the initial weight reduction, and again for maintain the loss with the dietary modifications and increased physical activities. Again, we should be advising them most of the times, these women, when they come to us for any consultation and we find them either overweight or obese, we should be advising them what are the benefits of losing weight, improving, preventing certain medical conditions, improving their chronic diseases, increasing their fertility, having better pregnancy outcomes. So it's again related to the advice, and patients should be encouraged to achieve and maintain more than about 5 to 10% weight loss, which is not very easy to maintain. I think they may lose the weight 5 to 10%, but to maintain that weight loss of 5 to 10% if by dietary modification or lifestyle modifications, very, very difficult. So we do strongly have to recommend that patients see their nutrition and exercise goals. And again, the problem is what type of nutrition they will like. We can't tell them, no, you have to stop, like what you are eating, don't eat it, and you go to a different. So you have to tailor it to their nutritional, what they are used to the diet and the food. And again, they need to monitor themselves at least a week. Once a week, at least they need to weigh themselves to see how they are doing. Because if you leave it for a month, it's going to go back as we heard before. And any goal setting should follow the SMART method. We know we have to be very specific. We have to be able to measure it. We have to make sure that we can attain it. And it's a real time bound to facilitate the progress. So these SMART goals are always very, very difficult. Even when I write the appraisal and I am supposed to write SMART goals, it's not that easy. And we need to encourage to maintain the frequent follow-up with the patients. The problem with all of us is we'll see them and then we forget about them. We give them the medications or even anything, and then we forget whether they are. So they should be given an appointment to be followed up and reviewed, and again doing the nutritional and exercise habits, see how they are doing, and so that what are their challenges, are they going for any holidays, what's their next follow-up required. And again, we need to have other people with us in the run. And it's not only gynecologists, we need everybody on board with us, I think what's necessary possibly is to increase, to have a management of the obesity as a subject in the medical schools and even in schools, because that's where we can start from early childhood, going to the adulthood, and as well then the later on in life. So this is one of the studies when they asked, they sent a review and found out, let's see what are the problems which people are facing as gynecologists, discussing about the obesity management. And what was the main problems? Reimbursement, which is everywhere, the insurance and the reimbursement of the money, not having enough time to do this. And again, as an obstetrician or gynecologist, not having much knowledge about it. So they need, having better referral services, having better reimbursements, and again, too difficult for patients to change. And again, some of us are very scared of, we may not offend the patients, and we are not trained to do it. So again, training is very important, time is important, money is important, and referral services is required if they need, for example, you find somebody who is struggling with a BMI of 45, you've tried your best, you want to refer them to the surgeon, or they are having comorbidities and the BMI is 40, they are not able to achieve with all these interventions. So you really need to have a very tight referral processes. Even you need a psychological counselor in your group who can counsel these, because these are very depressed at times. I think we see them as obese, but they themselves may not be liking to see themselves in that shape. So we need to have somebody whom they can talk and get the encouragement to have the weight loss on board with them. So I want to say, despite the time restrictions, a continued education and options for treatment of obesity is extremely important. Yes, OBGYNs can play an important and essential role in helping these patients to persist weight loss, even to use the anti-obesity medication treatments, and can give them some practical tips how to lose the weight and how to manage the side effects. And treating obesity in OBGYN patients could lead to fewer complications, better outcomes, and better chances for future pregnancies, and even better health risks and for their future generation. Because if you go to Barker hypothesis, you start your life in utero. So if you want to reduce their complications, possibly OBGYN doctors can play a big role in the management of these obese women before pregnancy and during pregnancy. And I will stop here. Thank you, and we can have a discussion.
Thank you, Dr. Saleema. Dr. Barbara, would you share with us your, from an endocrinologist point of view, any comments on these guidelines? Dr. Barbara, you're muted. We cannot hear you.
Sorry.
Dr. Saleema, you can stop sharing your screen. Thank you.
I was just thanking Dr. Saleema for a really fantastic summary, really highlighting some of the issues, challenges, and problems that we all have. So I think, as a gynecologist, I think we all agree that weight management is an important aspect of well, obviously, you discussed it so beautifully, showed us so beautifully, how weight can improve fertility, but also how difficult it is in our clinics to manage obesity, to raise the topic of obesity, the sensitivities around it. I think, what's probably important is to, I guess, have services or to work with people where at least you can refer to, because I think it's going to be very challenging, in a busy gynecology clinic to manage the weight aspect. But I think it's important to raise it, to have the conversation, I think, in the gynecological clinic. And one of the things that really struck me was what you said about, for every one change in BMI, your fertility increases by 10%. And I think, that's if you tell women that, I'm sure that those women, especially those who, who are really seeking fertility, I think that's a great carrot to have. But I think on the whole, what we find is if we raise the topic, patients are actually really grateful that you raise the topic. I know we're quite embarrassed to raise the topic about obesity, but are experiencing that they're just quite grateful that somebody is talking about it. And of course, it's important to do in a non-stigmatizing way and to say, look, this is, obesity is not your fault. It's a number of genetic and biological factors, but we can help you and there are things that we can do. I think when they come to the fertility clinic, usually it's a little bit too late, of course, because at that point they're like, oh, I want to get pregnant now. And of course, weight management should be something that starts much earlier on in life. As we should be looking at our 18-year-olds, indeed our children, and really addressing, weight much earlier on in life, so that when they come to us, or at least to the gynecologist, it's like, oh, it's not like a panic. Oh my goodness, we're going to have to put you on the contraceptive pill if we're talking about pharmacotherapy, because you can't really get pregnant, with Saxenda or liraglutide, for example. So there's a lot we can do, but I think ultimately, yes, do raise the topic, the importance of it, and really try and work with your local services. I think your endocrine colleagues, your obesity physicians, or to set up services which don't exist to manage what is a huge problem, because of course it's not just about fertility. Our sleep physicians will refer us patients, our liver colleagues would refer us patients, our diabetologists have got the same problem. I mean, in diabetes, weight management is not at the center of diabetes management, and of course it should be. And so yes, I think it's a good, it's the start of a conversation, of a very long conversation, and hopefully changes in how we manage patients. So thank you for that.
I think I'll ask Dr. Alia if she can put something on it, because being in the Emirates Society, what are you planning to do as an awareness to the public about the obesity? What role we can play? As you said, there is a lot of money which has been kept aside for obesity management. What's done for the prevention point of view or management of that?
Actually, a lot has been done, doctor, at different levels. As I said, the government actually has put a spotlight on obesity. And because we are looking into the future, they have put priority on obesity in children and adolescents, because they are the future. That has been a top priority since 2015. And they had many initiatives, many awareness campaigns in schools to educate them when they're young. In addition to obesity across all age groups. In addition, there was also a move towards healthy Dubai, where the aim was, okay, you can't just let the doctors do the pills and the management and all that, but as a government, what do we do? So one of the strategic national goals was to get people moving, and healthy lifestyles and well-being is a major thing. We even have a ministry of well-being. Focusing on the urban planning, on having these initiatives 30 by 30, which was during this, it's actually going on, 30 by 30 challenge, and many more actually across UAE. At EMA, of course, we are partnering with strategic partners. I mean, this session is one of a series of sessions with different specialties to put obesity, to the spotlight on obesity and the comorbidities and all specialties to play a role in this awareness move. I think what we really need to do in EMA and as doctors and colleagues is, how do we work together? We always say multidisciplinary approach to everything. But multidisciplinary approach is actually to tackle a problem. Where here, the challenge is before the actual problem happens, how can we prevent it? So I think we all play a role across all specialties. And I believe this series, and thanks to Novo Nordisk for this, really play a role. Maybe at some point we need to have part of the session which has actual audience, part of it. If I come from a family which has diabetes, coronary heart disease, all these family inherited risk factors, I would want my children to know from a young age what to expect to be able to avoid it, because kids now are much aware than when we were. So yeah, I think it's effort put by all of us together is where we can make a difference.
Good. Georgina, is there any questions in the chat box or Dr. Alia?
Yes, I believe we will move on to the Q&A session because the questions have actually started coming in, and we do encourage the audience to send through their questions. In the meantime, I will start with what we have received so far. This question is for you, Dr. Barbara. The question is, what about slim individuals with PCOS without any family history of PCOS? How would you manage those?
Thanks for the question. So, you know, we're absolutely right that we see about, I guess, 20% of patients with PCOS who are lean. And how do I manage them? I guess, you know, some studies have looked at their metabolic profile, of course, and I still, you know, insulin resistance still seems to play a part, you know, in lean individuals with PCOS. So, as I mentioned, with PCOS, it depends on what the problem is. Of course, weight is less of an issue for these individuals, but they may have obviously the hyperandrogenism, the hirsutism, acne, and/or irregular periods. So what I tend to do is tackle the problem. If it is irregular periods, then and like I said, weight is less likely to play a role. But sometimes insulin sensitizers like metformin, for example, can still help, you know, to regulate their period. So, like I said, polycystic ovaries, ovarian syndrome is you know, the pathophysiology. There's still a lot that we need to learn and understand. Like I said, in these individuals, leanness can be a little bit confusing, but I still think somehow that they do have insulin resistance, and that's the main problem, which leads to the hyperandrogenism and the ovulatory dysfunction.
Thank you. Dr. Saleema, how do you convince women with overweight and obesity that need to lose weight despite some cultural acceptance of overweight being like healthy and good? Like, you're in good health if you're obese. And so from your experience, how do you convince them? How do you convince these women?
A bad task. I think if I tell anybody that we need to lose weight if you want to get pregnant, she says, oh, I have a neighbor who is much more obese than me and she is 70. So I really have sometimes a lot of odd questions to answer. I tell them, no, but you need to think of, I don't talk about pregnancies or fertilities much. I talk to them about the long-term comorbidities. I tell them about, I ask the family history a little bit. Anybody in the family has diabetes, hypertension, or this and this and this. And they come up. I said, you know, there is a possibility that you can minimize it by doing this. But what I have found in my clinic, especially, majority of patients are mine, don't do diet, don't do exercise, they just go ahead with the sleep aspect.
Yeah. I saw a lot of those when we were doing the women bariatric team. It's like, just enough of that. That's the only solution. I will not starve myself. I love food.
Correct. And that is what is happening in my clinic. And I do need regularly follow them up because they fall pregnant very quickly after that without anti-fertility treatments or anything. So in that situation, if you ask me how easy they see, some of them, yes, try their best, but believe me, some of them don't lose. They definitely try their best. They come in 2 weeks or 3 weeks, you'll say they have lost about 2 kilos, and they come back after 3 months or 4 months. As I said, there is no continuation of the care. They come after 6 months or 7 months, they have gone back, even added one or two more kilos. So it's not an easy task by asking the lifestyle modification. I think lifestyle modification should be focused on the school children. I think what is good now, which I enjoy and reading, even though I don't like the food taste of that, and that's Wakaya. I'm sure you know about the Wakaya program. Food is, yes, you know, just Barbara, for your information, here the government has instructed that schools and hospitals and the shops should have all the labeling of the caloric content and everything. In addition, they should not have unhealthy food available in the schools, in universities, and even in hospitals. And in my hospital as well, when we go for our lunch, we have to take Wakaya.
Well, I guess it's a good thing in the long term. It's, you know.
Low in salt. It has low calories. It gives you the value of how much calories it has, but it has low salt. And with low salt, it's so difficult to take. Yes, it is a problem. So I think, yes, it's not that easy as we speak about that we should be playing a role to lose weight or anything. Is not that easy a job.
Dr. Barbara, a question. For women who have undergone bariatric surgery, post the 5 years weight gain, would you repeat the same steps in the algorithms in managing obesity in such women?
So these are women who've had bariatric surgery, have lost weight, but have regained weight.
Yes.
Yeah. So I think, so first of all, going back to the principles, you shouldn't just be doing surgery unless you've addressed you know, any mental health problems before surgery, the lifestyle changes, and there's a lot of education that needs to go on, because like I said, a lot of women, especially probably where you are, I suspect, they just they think it's an easy way out. They think, oh yeah, I'll have the surgery and that's, you know, that. So absolutely not. And that's why I absolutely stress that we need lifestyle, you know, in combination with the surgery, and they need to understand that, you know, the obesity is a chronic disease, and even after the surgery needs to be chronically managed, apart from the fact that they need to be on lifelong multivitamins and nutritional replacements. So, you know, a third of everybody does regain weight. Sometimes, and there are different reasons for that, but, you know, in terms of management, so lifestyle first of all, psychological interventions to try and work out, you know, what's going on, are there any addictions or anything else. There is some evidence now that some drugs, including GLP-1, you know, agonists, can be beneficial, in addition to, you know, like I said, we don't have masses of clinical trials, but there is some real world evidence and some clinical trials suggesting that they can be helpful. Sometimes, depending on the type of surgery, we can think about revisional surgery as well. So you know, it's an algorithm. Like I said, not much evidence in terms of pharmacotherapy, but certainly GLP-1 agonists have shown to have an additional beneficial effect. But it is tricky, of course, and I'm sure long term we're going to be seeing obesity, you know, weight regain managed with multi-pharmacotherapy, like we do many diseases.
Yes, thank you. Dr. Saleema, in your clinical practice, which is more common cause of fertility issues? Is it the male or female obesity? And do the males respond positively to weight loss discussions? Do they actually attend even those clinics?
As well, because I don't do fertility, but I refer my patients to my fertility expert. And I think the good advantage of our fertility expert is she's an andrologist as well. So yes, she does talk to them. And we see at least 1/3 of our patients do have a purely male factor infertility. So yes, having an andrology background, so it gives her a bonus to talk about the male, you know, obesity issues. I think it's not that easy to even, I don't come across much of the men to talk to them about the weight loss. No, the answer is here. I think here the problem in this part, you will agree with me, Dr. Alia, is obesity is not addressed as a you know, that you have to do the lifestyle modification. The easy way is go and do the bariatric surgery. And most of the bariatric surgeons don't have any nutritionist with them. They don't have any psychological counselor with them. They don't have anybody with them to check them. Just go and cut the stomach is the answer to the most, or bypass is the answer. I think, again, it needs to be taken as a, yes, if you are doing these surgeries, you need to have not to allow them to gain the weights and to get back into that shape. They need to have a continuous lifestyle modifications as well. I think that again works if you have a prior counseling with them regarding discussing before they go for surgeries.
True, we've actually faced that when we had the bariatric team, post-bariatric team, we have identified that as a challenge. And sometimes you actually find the couple both obese, but need to be managed a little bit differently due to the female, like, you know, there's always a special side to the female, different needs, maybe different requirements. You need to give her that emotional support to actually get her to a stage where you motivate her to have that change in lifestyle. Dr. Barbara, this is a question that we had received. What are the uses of metformin in obesity and PCOS, and can we combine Saxenda with metformin?
Thank you for that question. So first of all, I should say that metformin is not a weight loss drug. Okay, so you know, we use metformin to improve insulin sensitivity. You know, of course, you know, metformin has been, of course, used in patients with diabetes for exactly that same reason. And so what we see in patients with PCOS, and again, the literature is a little bit heterogeneous on this, but in terms of, you know, what we see in real life is that giving metformin can help to improve periods. It doesn't help so much with weight loss, but I do find that, you know, ladies with PCOS, when they take metformin, they're able to stick to a lifestyle intervention a little bit better. But, you know, it is not a weight loss drug. Otherwise, we would be using it as a weight loss drug, you know, for other patients as well. Now, can it be used in combination with Saxenda or liraglutide? Yes, of course. So for the treatment of obesity, it can do. So, you know, if you are going to start the medication, I probably wouldn't do it both at the same time, because, you know, they can both cause gastrointestinal side effects. So, you know, I would start perhaps with metformin first, make sure they're tolerating it, or maybe, you know, prescribe the slow release form and then add Saxenda. But yes, of course, they can be used in combination.
Thank you, Doctor. There's, on the same note, there's another question, which is, for how long should liraglutide be given to the patient? And some patients prefer a few months of treatment. Will this be useful?
So if we take the fertility issue aside, you know, pharmacotherapy for obesity should be taken actually lifelong. Okay, so it's not like oh, here's a 4 months intervention, you stop and you're going to be fine, because actually, like I said, it's a bit like saying you're treating blood pressure. If you take, you know, if the blood pressure goes down and I stop the blood pressure medication, your blood pressure goes back up. And it's exactly the same with weight, you know. So if I stop the weight medication, every single clinical trial has shown weight regain. Now, having said that, if of course the purpose is, you know, weight loss for fertility, and, you know, then I think you need to, you know, look at your individual patient, look at their age, look at their fertility plans, and plan together. So there isn't like a right, at the very minimum, of course, should be, you know, 4 months, I guess, but that at best would probably achieve 5% weight loss. Is that going to be enough for fertility? I don't really know. So I think you need to discuss, you know, what is a reasonable amount of time to wait before you actively try for pregnancy. So if it's 6 months or 1 year, during which time you're on the medication and you take some sort of contraception, and then you stop and try for fertility, bearing in mind that, of course, you are likely to regain, but, you know, with very good lifestyle intervention and behavioral modifications, you know, there's a good chance that, you know, for fertility purposes, you know, weight will be maintained. But, you know, I think every case is individual.
Doctor, another question on the same note. Are there any investigations needed before starting liraglutide 3 milligram, and any investigations needed during the follow-up period of the same?
So, I mean, usually with every patient, you know, we just, you know, it's always good to have some sort of basic workup in terms of full blood counts, you know, vitamin D, ferritin, their liver function, you know, just to really map out biochemically where they are, and of course to establish whether they've got diabetes or not. And again, if it's fertility, then you will probably do other things, check a prolactin, check an LH and FSH. So, but specifically, we like just to do just some general biochemistry. I don't think there's anything special. An HbA1c is useful, and to look at nutritional status, I think, because a lot of patients with obesity are nutritionally deficient in many macronutrients. But otherwise, in terms of follow-up, not specifically, not particularly, I don't think there's anything that you need to do. But obviously, if they've got diabetes, it's nice to see whether that's improving. If they've got abnormal liver function tests, you probably want to check why they're sort of abnormal in the first place. Do they have fatty liver? Do they have NASH? But no, otherwise, like I said, as long as you're happy with the sort of baseline biochemistry, then patients are usually fine, and you can just perhaps do a yearly metabolic workup.
Thank you, Doctor. Dr. Saleema, I believe this question is for you. We see many women gain lots of weight after giving birth. What is your approach with those patients?
I think that needs an antenatal advice during pregnancy, before they deliver, to tell them that, yes, you need to lose the weight, and we encourage the women to breastfeed. And breastfeed, believe me, is a very, very good way of losing the weight. And as well, to tell them, just to motivate them, oh, you really need to go back what you wear to have a better body. And, you have to be little play with your words, and you need to tell them that if you don't lose it, every pregnancy, you are going to gain your weight. So it's only a question of motivation. And I think if you talk to them, many of them do want to go back to their own life. If not for themselves, the family, the husbands want them to go back to them. So again, it depends on how you need to start it during pregnancy. After delivery, you may not see them. So the best thing is to start that question. Listen, I will just give you tips what you do when you deliver. After delivery, breastfeed your baby, start your exercises. If you have normal delivery, you can just walk. On the next day, start walking, start going out, start your exercises, what you were doing before. And many of the people want to say, hey, what about swimming if I don't go out to the gym? And, oh, yes, go ahead with the swimming. I think it's, again, starting a conversation during pregnancy so that they can think that they may be difficult to lose the weight.
Thank you. Dr. Barbara, what are other non-GIT side effects of Saxenda, and are they common? And can Saxenda be combined with hormonal therapy for obesity and PCOS for obesity and PCOS patients? That's a long question. Would you like me to break it down for you?
So I think side effects, apart from non-GI side effects. I guess I don't know whether gallstones or acute cholecystitis is part of that, but if we get very rapid weight loss with anything, actually, there's a higher chance of gallstones and therefore acute cholecystitis. But all of the events seen in clinical trials and in real world data are usually mild and reversible. In terms of, hypoglycemia usually is in patients with type 2 diabetes, perhaps on insulin and or gliclazide, and because again it's important to reduce the doses of insulin and gliclazide rather than actually Saxenda itself, liraglutide itself, causing hypoglycemia as such. So it doesn't, so again, it's all very mild. Some, like I said, on the whole, some patients will experience some headaches and some tiredness, but that's very rare. Not really, so the majority is really very much, gastrointestinal. But if you take paracetamol, there's a long list of side effects. But really, the majority is all nausea, constipation, diarrhea, yeah. So nothing really worrying that sometimes I get asked about thyroid, and because, I think I think there's, if you have a history of medullary thyroid, cancer or MEN, then of course you shouldn't use liraglutide, because rodent studies, studies with rats showed an increased risk of medullary thyroid cancer because rodents, rats express the GLP-1 receptor in the thyroid. Now we've not seen that in humans. We've been using Saxenda for well over a decade, probably 15 years now. So no specific side effects. And in terms of using it, so the second bit of the question was using it with
combined with hormonal therapy for obesity and PCOS.
So it depends what you mean by hormonal therapy. So you can certainly use it with metformin. You can use it with anti-androgens like spironolactone. I mean, I can't think of any sort of particular contraindications, to be honest. If you're on gliptin, you stop the gliptin. That's not a hormonal treatment, but I think pretty much, as far as I know, you can use it. Yeah, I can't think of any specific contraindication.
Okay. I believe our session has come to an end, and we'll move to the closing remarks. So we'll just put on the slide of the closing remarks. Thank you. So in regards to the closing remarks, there are 5 main points, at least, that we can summarize here. One is that obesity is a chronic disease with multiple women's related complications that requires long-term management strategies. And PCOS and obesity are strongly linked. Weight loss is the first management line for PCOS. Obesity affects both natural and assisted conception, and lots of literature highlight the benefits of weight loss in infertile patients. Gynecologists can play a big active role in managing obesity. Liraglutide 3 mg with lifestyle changes can lead to 10% weight loss, which is the required weight to lose weight loss to achieve a clinical benefit for the patients. Doctors, colleagues, and audience, thank you very much for your time, and thank you, doctors, for sharing your vast experience and knowledge with us, and may we meet again in another session that will have an impact in the way we manage and increase the awareness of our patients. Thank you
very much for being there. Thank you.
Just to also re-emphasize that the certificates of attendance will be sent to your registered emails once the accreditation outcome is received from the DHA. In addition, I believe there's a short survey that we would kindly appreciate if you can spare a few minutes to answer in regards to today's spotlight on obesity and obstetric gynecological diseases. Thank you, Dr. Saleema. Thank you, Dr. Barbara, and good night. Thank you.
Thank you, Dr. Barbara. Thank you.
Thank you, Dr. Saleema. Thank you, Dr. Alia. Pleasure to be here today.
Pleasure to me as well to meet you. Thank you. Bye-bye.